I have the pleasure of inviting the next speaker, Professor Laila AbdelWareth. Her titles exceed in probably 5 minutes of speaking, but she is the Chair of Clinical Pathology, Clinic Abu Dhabi, Acting Executive Director, National Reference Lab, the General Clinical Professor, Department of Pathology, College of Medicine and Health Science, Khalifa University of Abu Dhabi. She's going to take us through lab diagnosis of coenzyme Q deficiencies.
Thank you very much, Dr. Saeed, for the kind introduction, and thank you, Dr. Walid, for an excellent presentation. Good afternoon, almost, so good morning still, ladies and gentlemen. I'd like to also thank Dr. Ayman and the MENA Organization for Rare Disorders for organizing such an outstanding event, honestly. It really is important to shed light on these rare disorders. Today I am going to talk, unlike Dr. Walid, on truly a very rare disorder, which is the coenzyme Q10 deficiency. So this disorder is like 1 in 100,000 incidents. So it is really a very rare disorder. So we'll talk about the cellular functions of coenzyme Q10 in humans. We'll talk about the features of its deficiency and the genetics behind it and how to diagnose this condition. Remember, I work in the laboratory, so diagnosis is an important aspect. So I will start with a case scenario. This is a baby boy born to non-consanguineous parents. And within 24 hours after birth, patient or baby presented with cyanosis, lethargy, decreased spontaneous movement, hyperexcitability, and mild hypotonia. There was no relevant family history from both parents, and the baby then developed refractory epilepsy, psychomotor delay, nystagmus movements, and non-nephrotic range proteinuria. On laboratory investigation, the baby had an elevated blood lactate levels. The CSF lactate was also elevated, together with both CSF and plasma alanine. And these are usually found in babies or children with mitochondrial disorders. This sort of pattern is usually found in patients with mitochondrial disorders. He also had an abnormal urine organic acid examination with increased excretion of succinate, fumarate, and 2-oxybutyrate in urine. His plasma coenzyme Q10 was actually normal. However, on skin and muscle biopsy, the levels were significantly reduced, and that what gave the case away and proved the diagnosis. So this is an HPLC chromatogram of this particular patient. So this actually was a case reported in clinical chemistry, and I took the case right out of the journal. And as you can see, our patient here is A, which is the top chromatogram. Down below is the control, and that's usually what we do. We run controls, normal controls with patient samples. As you can see in the control below, in the CQ, after the CQ9, there is the CQ10 peak, which is completely absent in our patient. So the level were very, very much reduced as compared to normal controls. Further investigations included NGS or genetic testing with the clinical exome panel that confirmed basically heterogeneous missense variants in the COQ2, which is a gene, one of the genes actually that controls the synthesis of CQ10. So he got one mutation from dad and one mutation from mom, which at the time when this case was diagnosed were not really considered pathogenic mutations. However, they were considered variants of undetermined significance. But then when the case was further worked up, the deleterious effects of these missense mutation were indeed confirmed. So we'll talk a little bit about coenzyme Q10, and I have to say, after I prepared for this talk, I decided to put myself into coenzyme Q10 because of the myriad effects of this substance, I would say. So Q10 is a lipid-soluble molecule, and it is composed of a central benzoquinone ring, you know, that benzene-like ring there, and then it has a fatty acid or a lipid tail basically attached to it. Now, the central benzoquinone ring is important. This is the functional moiety of this coenzyme Q10, which is very important for the redox, so oxidation and passing of electrons, so the redox and antioxidant functions of the CQ10. While the lipid tail help the coenzyme Q10 to be present in the membrane of predominantly all cells in the body. So the synthesis of the Q10, actually the body can produce Q10 and can produce Q10 very efficiently until the age of 50. And this is why I started putting myself on Q10. Then the reduction or the production of Q10 decreases dramatically after the age of 50 to less than 50% of the normal production rate or synthesis rate. So again, the synthesis of it is very simple, and it comes from two pathways. One from the tyrosine pathway, which basically gives the benzoquinone structure, that benzene-like ring structure, and the other pathway actually gives it the lipid moiety, and it comes from the polysaccharide and the mevalonate pathway. Again, it's a very complicated pathways. Now, the fusion of the lipid tail to the benzoquinone structure is mediated by an enzyme which is synthesized because of the effect of the COQ2 gene. Now, there are many genes involved in the synthesis of COQ10 or coenzyme Q10. There's about 10 genes so far known to us, the PDSS1 and 2, and then the COQ2, 3, 5, 6, 7, 8, 9, and 10. And each one of them regulate, and I do apologize for the quality of the projection a bit, but each of these contribute to different steps in the biosynthesis of coenzyme Q10. Now, the main function of coenzyme Q10, as you can see, this is now the mitochondria, and it really is important for the mitochondrial respiratory chain, and it transfers electrons from the complex 1 and complex 2 to complex 3. And that simply, ultimately, will lead to the production of ATP, which is the energy-producing molecule. Now, deficiencies, I would say compound deficiencies, of the COQ10 genes, as in our case, will lead to primary COQ10 deficiency. This is again the illustration of the function, or the cellular function of coenzyme Q10, basically the transfer of that electron from complex 1 to complex 3, and then ultimately the production of ATP. So when this process fails, the mitochondria is unable then to produce ATP, and this is why the symptomatology are very much resemblant to mitochondrial disorders, really. Another important function of Q10 is it acts as a very powerful antioxidant molecule. So it does really protect the body from the harmful effect of the oxygen-free radicals and so on. And this is also a very important topic by itself in health and longevity that we can talk about, but in a different forum perhaps. So when it comes to Q10 deficiencies, they are categorized into either primary Q10 deficiency or secondary Q10 deficiency. The primary Q10 Q10 deficiency, as I shared with you earlier, are because of mutations in any of the 10 genes that I shared with you earlier that control the synthesis of Q10 in the body. While the secondary Q10 deficiencies could be because of other disorders that could indirectly affect the Q10 body synthesis, including things like PKU, maple syrup, mucopolysaccharidosis, other mitochondrial disorders, some of the drugs, particularly statins, and that's also important in adults to know that, and amitriptyline, which is one of the antidepressant treatments. And this is basically how these secondary disorders can affect the biosynthesis of Q10. I'm not going to bore you with the details of that. Now, primary Q10 deficiency presents with 5 main, basically distinct clinical phenotypes, and they are very heterogeneous. And this is why this condition is very tricky actually to diagnose. The most common one is the cerebellar ataxia and atrophy phenotype or clinical presentation. But these disorders can also present with encephalopathy, severe infantile multi-system disease, which is what our baby had, steroid-resistant nephrotic syndrome, so really very strong nephrotic syndrome, and then, as I mentioned, the cerebral ataxia and isolated myopathy. Again, the clinical features are very heterogeneous in this particular disorder, and also the age and presentation can be very heterogeneous, from infancy to early childhood to adulthood as well, like, for example, in cases of myopathy, for example. So, and then the genetic defect also weighs or plays an important role in determining the phenotype as well as the response to treatment. So our case here has the COQ2 genetic defect here, which leads to this multi-system presentation, which is, this particular condition is very fatal. However, it does respond to Q10 replacement and supplements. Other mutations like the PDSS1, for example, and 2, and the CQ9 perhaps may not respond as well to the Q10 replacement, but by far, most of the mutations would respond. So the diagnosis of Q10 deficiency, really the main important one is your muscle biopsy and measurement of the Q10 by HPLC. And the second mainstay in the diagnosis would be your genetic diagnosis or molecular testing using next generation sequencing. This is how you treat the case, and basically the protocols varies. You can give Q10 and the dose range from 5 to 500 milligrams per day, but these infants and children shows very dramatic response to Q10 supplementation, which is a very easy thing to do if you think about it. So in conclusion and summary, I hope I convinced you that Q10 deficiency really presents with a wide range of clinical heterogeneous presentation as well as genetic heterogeneity as well. The diagnosis is made by measuring the Q10 activity in skeletal muscle fibroblasts as well as by genetic testing using next generation sequencing. And it is important actually to identify this disorder, even though it is rare, 1 in 100,000, but the treatment for this disorder is very simple, and the outcome of it is very detrimental. So it is really very important to pick up these children or infants and treat them in a timely manner. These are some of the references, and I thank you very much for your attention.
Professor Laila, do we have time for questions?
All right.
Sorry.
Thank you. If you have a child, you know, and the literature mentioned that response to cognitive treatment or supplement is dramatic. So if you have a child
response, then you won't be able, obviously, to revise the diagnosis. Yes, so it's Q7.
Is despite having likely pathogenic mutation?
In the Q7 or the Q10?
Q7.
In the Q7, yeah. So that's probably maybe one of those resistant to treatment. There are some mutations that don't respond to Q10, unfortunately. So it could be also that one. But yeah, you have to try to the maximum dose to your point, and if there is no response, that could potentially be one of these mutations. The reality is we are really discovering more and more about this disorder, and not all of the mutations we actually know about, and also about the modalities of treating these disorders.
Okay,
thank you. Yes.
So I'm wondering if you could expand on the metabolic pathway blocker. I mean, specifically statins that many of us, they
Yes.
50 or 40
Yes.
are on. I mean, in relation to the basically.
That's an excellent
Is there
question.
expansion on that?
Yeah, that's an excellent question, and I believe patients should be tested, to be honest, before they are put on statins, because the problem is they will get myopathy and they will get muscle aches and pains and so on, but they don't know what is the reason for it. And they are probably either going to be put on Q10 supplements or consider other form of lowering cholesterol. But yes, statin will block the synthesis. I told you it is produced naturally in the body, but if you block that pathway, you block that lipid part that comes in contact with that benzene-like structure. So it does affect the functionality of Q10, and therefore I believe patients on statin should be given Q10 supplements. Excellent.
I mean, is there data on patients on statin having the Q10
Yeah, if
much lower or lower levels?
yeah. It will definitely affect the synthesis. I didn't come across studies looking at patients on statin and the level of Q10 per se, because that would require a muscle biopsy, and you can see how popular that would be to patients. You can do plasma levels as well, but they may not reflect the true deficiency. However, because of the biochemistry of it, it is well known that if you are on statin, it will block some of the synthesis of the Q10 in the body. Yeah.
Thank you for your fruitful lecture. As I was saying, many patients with MPS and you said that there is secondary causes of, for example, deficiency and PK. So you recommend to give those patients high dose, or what is the dose of, and the mechanism in MPS, maybe in PK, maybe there is no tyrosine and the pathway. I think that.
Yes, yes.
And MPS, what is the mechanism, the role of Q10 or Q10?
And what, sorry? Yeah.
What's the mechanism of the pathophysiology in the deficiency of
Yes. So the secondary disorders lead to deficiency because they interfere with the biosynthesis of the Q10 ultimately, kind of indirectly. For example, like the absence of tyrosine, for example. Yes, you have deficiency of the primary molecule that produces the substance itself. But if you correct PQ and if the tyrosine level are okay, the body should be able to overcome this. However, if those patients, and it is important to look for the symptoms of the Q10 deficiency in those patients, particularly the myopathies and so on, the nephrotic range proteinuria, and if you find these are present, then I think you should consider the Q10 supplementation.
So don't start when you diagnose.
If you are able to reverse the metabolic disorder, then they should be fine. But if you are unable to correct it, you should consider the Q10, because they will have secondary deficiency of Q10, and they will probably have some of the range of these symptoms as well.
Thank you.
Yes.
Thank you very much for the interesting presentation. I actually wanted to highlight an organ that has been underrepresented throughout the entire story. Unfortunately, it's ophthalmology. So actually, we are recognizing more and more mitochondrial complex 1 variants in patients with optic neuropathy that have been
systems pretty much were affected, the heart, the retina, I agree. And it does affect pretty much all organ systems.